Well, hi class. Welcome to week 2 of Kinesiology 353. I just kind of want to cover a little bit of our syllabus today just to remind you guys of how each week is going to go. As you already know, you got to make sure that you're checking your syllabus. For example, this past week we had different chapters we're going to read, the discussion board, which over here on the right hand side it tells you what date or I'm sorry, what day of the week you're supposed to turn that in by. So make sure that you guys get all of your discussion boards done by Wednesday at midnight, and that includes every post. That means your post, and then remember your I think pretty much every discussion board you're going to have to respond to a classmate's post as well. I think there's only one or two that I don't require you to do that. So, but make sure you're reading the instructions on that. Assignment 1 was due on Sunday by midnight, and also your quiz 1 was due by Sunday at midnight. So make sure that you guys are keeping up with that. This next week we have chapters 18 and 19. So we're doing the ankle and the foot, and then you have your discussion board 2 on barefoot running, which is due on Wednesday by midnight. And then the last two assignments are going to be for Sunday by midnight, which is a coach interview and quiz number 2. Okay, and one of the other things I wanted to just remind you of is our article reviews. So we're going to have 2 article reviews, and those come with specific instructions, and then we're also going to have a critical assignment, which is going to be a 3rd article review. So let me just come over here just to remind you of how that works. So like it says here, it says there will be 2 article reviews throughout the course. Articles and questions will be provided, and you have to read the articles that I provide you with and then answer the questions that are attached to that. In your critical assignment, it will be your own reviewed scientific journal article that you're going to find. So I'm going to post a separate video just for that, just to kind of give you guys more specific instructions and some examples of how to do that. But basically, you're going to go into the library's website, use their search engines, and go through the scientific journals and look up um, articles and peer-reviewed articles, and then you will have to review that article. And I already posted instructions on how to do this review. There's going to be specific sections that you have to cover, and it's all going to have to be in APA format. So you got to remember to read those instructions, and that's going to be due on by midnight on Sunday of week 7. So just to kind of show you here, your first article review is week 3, and it's going to be on ACL injuries. So that's already posted on the week 3 folder. Article review 2 will be week 6, and that is going to be on pitch type and count. And then week 7 is when your critical assignment is due. So I would suggest that you guys get started on that, start researching different articles on, and I kind of leave it open, but it has to be related to injuries, sports injuries specifically. And if it makes it easier to choose, like I would look up specific injuries. So whatever injuries that we're covering, those are a good place to start. And the other thing that you can do is if you look at the 2 articles that I've given you, you can start looking at the reference page that they have at the end of those articles. And those are good places to look for some authors and some titles of articles that you can use to do your own review. So, like I said, I'm gonna post a separate video just to give a little bit better instructions on that and clear some things up. But if you guys already have questions on that, please put that on a discussion board. Like start a new thread and label it, critical assignment questions, and you guys can post questions onto that. Okay, so today we're going to cover just some brief points on the foot and ankle and the chapters that you guys had to read today. So let me move over to this slide here. So the main thing I want you to know about this is the medial longitudinal arch. So here it gives you a description of the anatomy that makes up this arch, and that's a calcaneus, a talus, a navicular, the first cuneiform metatarsal. So you were looking at everything basically on the inside of your foot, and it basically is what creates your arch. So when you look at your feet and you're looking at arches, we're looking at the inside of your foot, and it's this arch right here. That is a medial longitudinal arch. One of the more important structures that you're gonna have to remember is the calcaneonavicular ligament, and this ligament can get injured a lot of times when you're dealing with athletes that are jumping or running. It can get sprained. One of the other names that it goes by is called the spring ligament. So anytime you have an injury to that ligament, it's going to be pretty difficult to put any weight on their foot, and it's going to be even more difficult to try to push off on their foot, because that's the arch that really provides all the support medially. And anytime you're pushing off of that, it stretches it. So if there's an injury already there, it's going to be really tough to do that. Okay, so the next structure that we're going to look at in the foot is the plantar fascia. So a lot of you may have heard of plantar fasciitis. It's very typical in athletes, especially overuse or repetitive athletes that have to run, jump. They're going to create a lot of stress in this plantar fascia right here. And when you're dealing with that, it can be kind of tough to treat, because it's a type of pain that when they're just walking, when they're doing regular activities of daily living, it may not really hinder them. But when it comes time to actually, um, you know, do a maximal effort, it's going to be a lot tougher for them to actually perform those things. So one of the things that you're going to come across in your readings is the windlass mechanism. So as this plantar fascia comes off of the calcaneus here, it's going to attach to the base of the metatarsals, and that is going to be a structure that's going to not have much tension when the foot is relaxed. But once you put these toes into extension, that's when this structure gets really tight. So um, in some of the for some of the special tests for the foot, um, initiate that movement. They passively, or the practitioner will passively extend the toes, and that will put this structure on stretch. And if they're having any pain, or if there's a disruption to this tissue, they're going to have pain closer right here to the calcaneus. The other thing that to note is that with plantar fasciitis, there's going to be a lot of things, or a lot of ways to treat this. There's going to be ultrasounds, there's going to be heat, icing, soft tissue massage, and a lot of these things are just um, things that have been given to athletes over the years, because whatever helps the athlete feel good is usually what is done. But one of the things that you have to take into account is just the biomechanical structure of the athlete. Do they have pes cavus? Do they have pes planus? That can guide you a little bit better in how you're going to treat the athlete. You're not always going to do the same treatment for every athlete. So, sorry about that. One of the things that is prescribed for plantar fascia is a shoe insert, especially runners. If they have a significant pes planus, meaning that that medial arch is really collapsed, they'll put medial support for them. So their shoe will have an insert where it provides that arch, or it creates that arch, so that not all the stress is is placed upon the medial side of the plantar fascia. One of the other things to note with plantar fascia is the symptoms. So the symptoms, obviously they're going to have pain when they're running or whenever they're doing their activity. But one of the main ways to note the severity of the plantar fascia, or to really diagnose the plantar fascia, is when they're getting some of this pain. Because athletes that have had this for a while will start having pain when they're at rest for a long period of time. For example, if they're getting pain as soon as they take those first few steps in the morning when they get out of bed, that's a good indicator of that. They've been resting all night, right? So they sleep on their back, they're not sleeping standing up. So this fascia right here has time to kind of contract or kind of recoil. And once you get back on your feet after all that, let's say 8 hour period of not being on stretch, those first few minutes that the athlete is standing and putting this on stretch is going to be very painful. Or let's say they're sitting down for a few hours and then they stand up and they start having pain towards the calcaneus or on the inside of the foot. That's a good indicator of plantar fascia. Okay, we'll move on to this next slide, and here we're just talking about some of the ways that the ankle is damaged. As you can see here, we're showing a lateral ankle sprain or inversion ankle sprain. And for the most part, when this occurs, you're going to damage the ligaments on the side here. So we have the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. And those are the three main ones that you're going to see that get damaged on the outside of the foot. And one of the other things to note is if you look at this ankle here, all these structures here on the sides, all the bony structures are also or could potentially be compromised as well. So one of the things that gets sometimes overlooked, or maybe you should take a second look at, is possible avulsion fractures, because we have some tendons that attach here to the fifth metatarsal. So the peroneus brevis attaches here at the fifth metatarsal, and that can cause an avulsion fracture. Another way that it can happen is just by mere contact with the ground, and that can cause a Jones fracture. So make sure that you're aware of those terms. The Jones fracture that can occur here to the base of the fifth metatarsal. So as you're palpating when you're doing an evaluation, you have to know where you're palpating. So these ligaments right here, the lateral ligaments, and then you're also going to palpate the fifth metatarsal. And like it says here, lateral malleolus, that can also be involved. Right here, the lateral malleolus, if the inversion sprain is severe enough, this can actually hit the ground. Or the CFL can be stretched hard enough to where it actually pulls off a piece of that bone, again causing an avulsion fracture here at the lateral malleolus. And another thing to note is a high ankle sprain. And this also goes by the name of a syndesmosis sprain. And what we're dealing with here, like it says in the bullet point, is forced dorsiflexion, meaning that the foot is going to get forced straight up. And this usually occurs from an athlete stepping in a ditch or a hole, where the foot gets forced completely up. And what happens is that the talar dome gets forced in between the tibia and the fibula here. So it gets forced all the way through here, spreading those two bones apart. Well, there is some structures that hold those two bones together, namely the syndesmosis tissue right here. And anytime it's severe enough, you can actually tear that tissue right there, that syndesmosis, and that's going to create this high ankle sprain. And the problem with that is anytime you have to walk and we'll get into this with our gait analysis, you need a certain amount of dorsiflexion. But if you're having a lot of pain with just dorsiflexing even a little bit, it's going to be tough to have a normal walking pattern. So just keep that in mind as we move forward here. Okay, so we get to this slide here about gait. And like I mentioned before, one of the very important parts of gait is going to be your ankle motion. And we see here and in your book that there's different phases to your gait. We have stance phase, swing phase, and you can even break them down to even smaller phases. But the point of this is for you guys to understand that normal gait or the average person's gait has a lot of these same patterns where you're actually making contact with your heel, and then you start loading the foot, and then you are completely putting all of your weight on that foot, and then you start making the transition into pushing off. And most of your weight is going to be on your metatarsals and your toes, and eventually getting into a swing phase. So one of the things that it notes in your book is that for normal gait to occur, your ankle requires 10 degrees of dorsiflexion. So the importance of that is if you can't get 10 degrees of dorsiflexion, that means when you get to this portion right here, the pre-swing phase, if you can't lift up your toes enough to get you to that swing phase, your toes are gonna end up dragging on the foot. I'm sorry, on the floor. So you need that 10 degrees of dorsiflexion to clear your toes off the ground. And obviously if you're an injured athlete, you're not going to let that happen. You're going to automatically compensate, and that is how you get that limp. You automatically start using your hip and your knee, so you start kind of swinging your whole leg through because you can't fully dorsiflex like you're used to. Otherwise, yeah, your toes would hit the ground. And that's where you start creating these other problems at your hip and your knee, because you start compensating by trying to clear the ground by using those other joints above the ankle. So keep that in mind. Make sure that you're aware of that. Read that in your book, and just remember that the importance of your ankle range of motion. And that's why as practitioners we document our ranges of motion, because we want to see where our athletes are and where we need to get them to, like what is going to be normal for them, and we can see the progress that they're making, and then we're able to compare that to, okay, how do they look like when they're just squatting, when they're walking, when they're running, and what do we need to work on, what do we need to improve, so that way we can focus our rehab more on the important things. So if I have an athlete who's just sprained their ankle, I already know that dorsiflexion is going to be really important for them to get back to doing functional things. So right away I start working on decreasing swelling so that they can actually move their ankle. And two is to start working on that range of motion, whether that be through manual therapy, me doing joint mobilizations and slight stretching. Maybe I need to stretch the Achilles tendon. Maybe that's gotten really tight and that's what's limiting their dorsiflexion. So I'll start working on that, so that way when it's time for them to start fully weight bearing and start to walk and run, they won't be inhibited by this lack of range of motion. Okay, on this slide, I just want to talk a little bit about rehabilitation and the different components of it. So first off, general body conditioning, and that just means that regardless of the injury, the athlete can always do something to maintain or improve full body conditioning. So if they have an ankle, in this case, since we're talking about the foot and the ankle, most athletes think, okay, I can't do anything. I'm just gonna sit around, gain weight, and not do anything. but that's not true. There's a lot of ways to maintain conditioning. One of the harder things, obviously, is cardio because most athletes are used to doing cardio by running, and so they think, okay, well, there's nothing else I can do, but that's not true. The pool is a really good resource to have. If you have a pool on campus, then they can do a lot of non-weight bearing exercises, swimming, jogging, using an aqua jogger. And then there's also the upper body ergometer, or it's basically a bike for their arms. Anything that will help keep their heart rate up. So one of the first things that we go through is weight bearing. So going from non-weight bearing to weight bearing by using correct gait. So again, what we were talking about before, making sure that their range of motion is getting back to normal, so that that normal gait can be a lot easier. And one of the tools that as athletic trainers we can use is joint mobilizations. So joint mobilizations, as you'll read in your book, are a way for the the practitioner to facilitate a certain range of motion by using accessory motions, and it allows the athlete to then go and do a regular movement with whatever joint you're mobilizing. Flexibility. These are all things that you just have to show your athlete that they can do on their own. There's no need for the athletic trainer to always have to do this for them. In fact, it'll help the athlete be more engaged if you have them do things on their own. Teach them how to do it a few times, and then tell them, okay, this is your responsibility. You got to do it on your own at home, or whenever your team is working out. You can or practicing, you can be out there on the field and do your exercises on the sideline or on the court, wherever they're practicing. Muscular strength, as far as the foot goes, there's not going to be a whole lot of heavy lifting going on with this. What muscular strength means for the foot is working on the intrinsic musculature. So all those small muscles in the foot, we can train them. We can help them do towel scrunches, and I'll show you a few slides of exercises here. So, but towel crunches, towel slides, picking up marbles with their toes. You can also do some manual resistance with them. So it's not really these big movements that you're doing, but something to make sure that they're engaging those smaller muscles in their foot. Neuromuscular control. So here we're dealing a little bit more with balance exercises. So we're just helping to train or retrain this portion of body movement. So balance exercises and closed kinetic chain exercises. So balance exercise, like it shows here, we can use an RX pad to challenge them a little bit in balancing. But it doesn't always have to be this RX pad. Maybe they can only, uh, you know, as far as being challenged, they can only do it on the floor. Like maybe they can only um, take the amount of instability as far as the floor, and not anything like the RX pad. Closed kinetic chain exercises, that involves just exercises that you're doing with both feet on the ground. So for example, the knee extension machine, that would be an open kinetic chain exercise. But in this case, to train neuromuscularly, we have to do things where we're moving everything above the ankle and the ankle is stable on the ground. And then the other things that we can do to help our athletes get back to normal is foot orthotics. So if we feel that they have a major discrepancy between one foot and the other, we can refer them to a specialist. And then there's also taping that we can do to increase or to help out their arch or any toe injuries that they may have. So if we look over here, we have a few exercises that we can have our athletes do. Okay, as far as the lower leg, one of this figure right here, this diagram, is going to be really important. As I was going through school, one of the things that we had to be responsible for is just knowing these major structures that that live here in the lower leg. So what we're looking at here is a cross section of your lower leg, or if you want to call it the shin, where we have the tibia. So this is the very front of your leg, and then we have the fibula, which is to the side of your leg. And what they've done here is separated. So if you cut it from the top, they've separated the lower leg into four different compartments. We have the deep posterior compartment, anterior, lateral compartment, and then the superficial posterior compartment here. So as you can see, we have a vein, a nerve, and an artery in our anterior and deep posterior compartments. And you know what you need to know about that is right here on just anterior and laterally to your lower leg, there's not very much padding between these structures and your skin. So anytime there's an injury there, it's going to be very easy to damage these structures. And that can be done indirectly or directly. Directly meaning if you get hit directly here, that you could damage some of these arteries and nerves. Indirectly meaning you can hit this structure so hard to where you create enough edema or swelling to the point that it's putting a lot of pressure on these important structures here, and that goes by that specific pathology goes by the name of compartment syndrome. And once you see that the athlete is complaining of numbness, tingling, that they have a lot of weakness, that's a time where you start to refer, because you know what is causing it. Obviously, if they have a huge bruise and you can see all of the swelling on their leg and they start complaining of these things, you can kind of deduce that, okay, this is the problem that's going on. If it's something where the athlete has no mechanism of injury, they didn't get hit there, they haven't been really complaining of anything, and all of a sudden they're saying that they're having numbness, tingling, then this could be strictly neurological. And either way there, you have to refer as well to a specialist. So let's move on here. And here we have some neuromuscular and balance training. And these exercises can be used for the foot and ankle rehabilitation programs. The next thing I wanted to just briefly cover are some of the special tests. So here we have a compression test or squeeze test, where we're looking to just squeeze the tibia and the fibula, and if any pain is felt, let's say at the ankle or at the lateral malleolus, medial malleolus, then you have an indicator of a possible fracture there. Bump test, another test to try to rule out a fracture as well in the ankle or in the lower leg. Thompson test, here we are looking for a basically a reaction from the foot. Anytime you squeeze the calf muscle here, then you should see the foot plantar flex. So this foot should move downward like this if you squeeze the calf muscle here. If you don't see that, or let's say you do this test on an uninvolved leg, and then you do it on the leg where, let's say, they might have strained their Achilles tendon, then you're going to see that you're not going to get that little flinch or that reaction from the foot. So there could be a possible Achilles tendon rupture there. Homan's sign, you guys can read up on. That one's not too important. Anterior drawer test. This is one of the tests that we get to use a lot because it helps us, or it's supposed to give us an indicator of severity of an ankle sprain. So what we're doing is we're pulling on the calcaneus anteriorly, and depending on how much give or how much translation we get, that will let us know, how much damage is done to those lateral ankle ligaments that we talked about earlier. And this test as well is going to be testing those lateral ligaments, the ATFL, CFL, and PTFL. And what they're doing here is just inverting the ankle here. So how far it opens will kind of tell you how much damage there is. And then also you can do this in an eversion manner, so doing it from in to out, and that will tell you how much damage there is to the deltoid ligaments. Kleiger's test is also a way to test the medial ligaments, but also the syndesmosis tissue between the tibia and the fibula. So what you're doing here is you're everting and dorsiflexing the foot, and obviously pain is going to be an indicator of a positive sign here. Okay, so this is the last slide I want to kind of go over, and it's our ankle and leg rehabilitation. So it's going to be very similar to the foot rehabilitation, but one of the things I just want to talk about is the fact that we have these different components to our rehabilitation protocols: neuromuscular control, strengthening, we have taping, bracing, functional progression, and return to activity. So a lot of these aspects that we include into our rehab protocols are there for a reason. We're not just trying to put our athletes through hoops just to so then just to kind of give them something to do, but they're all there for a reason. So we understand that our athletes are going to be doing a lot of dynamic movements, that it's not like they're just going out to the field and going for a quick jog. And depending on where you're going to be working, whether that be in physical therapy, athletic training, or strength and conditioning, that could be the case. Maybe you're trying to rehabilitate someone that all they're trying to do is take a bike ride. They do let's say a 30-minute bike ride 3 times a week. Maybe that's all they're trying to get to. That's their goal. Or maybe you're working with an elite athlete who needs to do a clean and jerk for their Olympic trials. So you're gonna end up working with a large spectrum of capacity with your athletes, but that does not change what goals you should have as far as rehabilitation. It's going to vary in degree, but all these components are still going to apply for each of those scenarios. So that's why it's important to document, to understand what's going to be normal for your athlete. So as far as neuromuscular control when it comes to the ankle and leg, it's going to be very important. You can't have someone go out for a jog or go out to play in a 90-minute soccer match if you don't feel comfortable or you don't see in the numbers that they're able to control their body. If they can't balance on one foot, if they can't even put weight on just that one foot without having a lot of pain and having and without being able to balance themselves. That's why it's important to make sure that you're documenting and that you're showing them, like, hey, look, this is where we're starting, and we're trying to get to the point where you don't have to think about balancing on that one leg, that you can actually push off of it. Strengthening as well. Strengthening is going to be something that has to be part of their daily routine. It can't just be, I'm going to come in once a week and knock out these exercises and then try to go to practice. No, that's not the way it works. And usually athletes try to do this. They try to go with a taping and bracing instead of all the strengthening and all of the other rehabilitation exercises. And as a good medical practitioner, you need to understand and need to make your athletes understand that there's no shortcuts. You can try to do this for a little while. Like, let's say you sprain your ankle and you take a few days off, and by off, your athlete thinks, I'm gonna just skip out on rehab, go watch practice, and not do any of my exercises, and then try to go back and just get taped and go back to practice. Well, they might be able to do that for a few times, but then they're going to start to notice that they have a lot of weakness, that they really can't push off of that foot very well. They can't kick as well. They can't jump off of it very well. And they're very tentative. And, they're just going to tell you, well, tape it tighter, or is there a brace that I can wear? Well, these resources are there to assist us. They're not there to replace all of the other rehabilitation aspects. So it has to be something that you put in place as far as how you want your athletic training clinic to be run. You have to put it in place right away. You can't let the athletes dictate how they're going to do the rehab. For example, our functional progression. This is one of the ways that we make our rehab as specific as possible to our athlete. So, and this is one of the ways that we try to make it more enjoyable for the athlete, or at least keeps them more focused on doing the rehab. If we start to include, whatever objects they use in their sport. So if it's let's say it's basketball, when they're doing their single leg balance, we start just having them try to shoot or mimic shooting free throws with an actual basketball, or catching passes with the basketball, or catching a football, if they're a wide receiver. Anything to make each part of the rehab as sport specific as possible, so that they feel more engaged and they don't feel left out of their team practices and things like that. So in order to return to full activity, they're going to need full range of motion and strength. And this can change sometimes, and I'm not saying because we want it to change, but because depending on what part of the season, what game that this athlete could potentially miss, their coaches, they're gonna start to want to get back to play as early as possible. And sometimes the athlete's gonna go out and play, and maybe they don't have that full range of motion that they really need, or the full strength that they really need. But how close to 100% can you get them? And during a season, not everyone's going to be playing at 100%. That's almost impossible. But one of the things you have to remember, do they feel safe? Do they feel like they can actually go and play? Or are they hesitant? Even if the athlete, let's say, has full range of motion and full strength, but they feel hesitant to go out there and perform, whether it be basketball, football, or whatever, that's something that the coach and yourself and then any other staff needs to discuss. Because if they're not, and they seem to be in danger because they're mentally not prepared, then that could be a reason to hold them out. Even if all of your objective tests say that they can. So again, just some things to think about. These are things that aren't really in your book, but through experience, these are the things that I've learned when going through rehabilitation. It's not, you go through each phase of the rehabilitation process, and you give your athlete as much as you can, but they also have to be responsible. They have to put in as much effort as you do. And the more background you can give them on their rehabilitation process, if you show them how they're progressing, where you want them to be by what date, if you give them more specifics like that, they're going to buy into the program a lot more, and they're going to be a lot more compliant. And when it's time for them to go back to play, they're going to feel a lot more confident about performing and not even having to think about that injury. So that's going to be the end of our lecture there. If you have any questions, please post them on the discussion board. If there's any specifics that you need me to elaborate on, just post it on the discussion board, and I'll get to it there. Thanks.